Thank you very much for the introduction. Thanks for the committee for inviting me. This is a 55-year-old man with mainly a risk factor of heavy smoking, presented because of chest pain after he played basketball after a heavy meal with his kids. His wife reported that he was evaluated 3 years ago by the same complaint, and they did the nuclear study, and that showed multiple area of reverse or lack of assignment of the isotope and then regaining. So they considered him that this patient may have multivessel disease and put him that you may need CABG. So he escaped and refused the coronary angiogram and any intervention. Continued to do well until just 1 week prior to presentation, when he played basketball and felt this epigastric pain. He considered that as a flu and remained at home, but his wife insisted that he should see a doctor. Even on the day he presented to my office, he went shopping with his wife and was able to walk along the mall without any problem. On the exam, what we noted that his blood pressure on the left hand is lower than the right hand. His ECG showed normal sinus rhythm and no Q wave, but T wave inversion all over. Echocardiogram showed mildly reduced LV function, ejection fraction 45%, and the Doppler of the left subclavian showed severe proximal stenosis. So this is a patient that you know that he's a denial patient, escaping everything, and so we have to bring him to the cath lab and not to consider the option of CABG, just do ad hoc complex intervention for that. So let's review his angiogram. This is his LAD. You see the total occlusion in the LAD. And this is his circumflex. You see the total occlusion in the circumflex and the obtuse marginal one. And this is his right coronary artery. You see the total occlusion in the mid-RCA with bridging collateral. Again, that. And this is his LV function, which is okay. Again, don't say that this patient should go to surgery. He will escape. So he asked me before going to the cath lab to swear to God that I will not send him to surgery. So this is, I did the angiogram for his subclavian. You see severe stenosis in the left subclavian involving the origin of the vertebral and the lima. Even with this lesion, you can't use the lima. And this is the angiogram on the other side, the right subclavian. And you see this is the angiogram on the last subclavian, and the carotid as okay, but you see filling retrograde of the left vertebra. That's called subclavian steal syndrome. And this is his carotid on the left side, which is normal. So I started with LAD intervention. You see that I crossed with, this is the lesion, and crossed with the wire, predilate. And this is the angiogram that the wire you see was going into small diagonal, and we redirected the wire. And this is the angiogram after predilation, showing even distal LAD lesion. So we stented the distal LAD lesion, and again stented the proximal LAD lesion at the site of the total occlusion. And this is the final angiogram for the LAD. So this is the circumflex intervention. We crossed the total occlusion of the circumflex, predilated with a small balloon, and did further predilation. This is the angiogram after predilation. We still have the total occlusion in the obtuse marginal. We crossed the obtuse marginal with another wire, predilated the obtuse marginal. And this is the angiogram after predilation. We did further predilation in the obtuse marginal. And this is the stenting of the circumflex. After stenting, we get this final nice angiogram, although the ostium of the OM has a pinch, but I would not do complex intervention for this bifurcation. So this is, we kept our promise for the patient. We did not send him for surgery, and we sent him home and brought him just 2 weeks later to do the intervention for the total occlusion of the RCA. You see we still have bridging collateral at the total occlusion. We crossed with a wire and tried to dilate with a balloon. After that, we did the angiogram after pre-dilation and advanced the wire. However, when we do the angiogram after that, we recognize that the wire is going subintimal. We are not going further. So there is no point to keep the wire and get another wire. Just put the wire back and re-enter again. So we re-entered again and entered to the PDA and did the pre-dilation, nice result, and we did the stenting. And this is the final angiogram. We did gain that. So we covered 3 total occlusion. And again, so we put the guiding catheter for the RCA, put it in the subclavian, the same guiding catheter, used the same wire, the same balloon of the stent, the coronary stent, did pre-dilation, and then switched to peripheral tools and put stent in the left subclavian. And with that, we got nice result. And you see filling now of the left vertebral and filling of the lemma. So the patient did well, and this kind of patient, Dina, refused any further evaluation, no further repeat stress test, no further any evaluation. This is my way of dealing with the intervention by using just simple methods, and this is the acronym for that, and this is the believer. This is the believer that God described them in the Holy Quran. قد أفلح المؤمنين. Truly the believer has succeeded. And he described them, they avoid, هم عن اللغو معرضون. They avoid any veil talk. So they refused any talk about whether this patient should go to surgery or not. This is our protocol, that we don't use any retrograde thing. We don't use any contralateral injection. We don't use any anchor device. We don't use parallel wire. All of that, I think, things just to show up or make the case complex. Just you do your simple thing. And with that, we were able to go outside the heart. This is a 23 centimeter total occlusion in the iliac. This is a total occlusion in the SFA. And you see how bad is the total occlusion. We went through the SFA down to the foot. And this is the total occlusion in the carotid. This is a very rare case. You see the total occlusion in the internal carotid and nothing going to the brain, inside the brain. And just, you left that. So just let me finish with that. Okay, good. So nothing going to the brain. It's total occlusion in the internal carotid, and with that we were able to open the internal carotid, and this is the angiogram. We got nice results, and everything is filling inside the brain. Even we have total occlusion inside the cranium. This is, you see the anterior cerebral artery on the left side is totally occluded and getting collateral from the other side, and this is the angiogram. You see how it's filling, nothing going to the brain from the anterior cerebral artery, and we were able to get on the other side, nice flow back to the brain. And this is another side. You see total occlusion in the middle cerebral artery, and we were able to recannulize that by our simple method, and we filled that. That's the last one. This is severe mesenteric ischemia, chronic mesenteric ischemia, nothing going to the mesenteric. Almost he's having dead bowel, and we took the patient from the table of the OR surgery because he's going to major resection. We were able to recannulize his all mesenteric arteries, and he ended up with resection of only 10 centimeters of this small bowel. and this is total occlusion in the superior vena cava. We were able to recannularize that in a patient with malignancy. Look at that, about 40 centimeter of total occlusion in the superior vena cava. So we are doing everything just with our simple method to believer. So I hope that you convince you, all of you, to be a believer in my way in opening total occlusion.
Thank you very much. Thank you.